Thanks, everyone. I'm Charlie Renner. I'm the second-year fellow, vascular surgery fellow at the University of Kentucky. Title of my presentation is Endovascular First Management of Acute Type A or Aortic Dissection, in this case with extensive malperfusion. The patient was BG. She was a 36-year-old female, 3 weeks postpartum with a history of substance abuse, including methamphetamines. No relevant past surgical history. She was on Suboxone, reportedly sober throughout the pregnancy, but seemed to have relapsed in the early postpartum period. She is actually admitted with a chief complaint of altered mental status and a GCS of 10, a lactate greater than 10. She was admitted to the medicine service for workup of her altered mental status. It wasn't until the next morning when an ICU nurse noted that she didn't have pedal pulses that vascular surgery was called. Urine drug screen was positive for methamphetamines. On our examination of the patient, she was extensively modeled below her umbilicus. She had weak pedal signals on the right and no pedal signals on the left. And then I do want to highlight here, laboratory work. While she was resuscitated, she developed significant transaminitis, acute liver failure, and then rhabdomyolysis with a CK that was off the charts. CTA of her abdomen and pelvis was obtained, showed evidence of a dissection throughout her entire abdominal aorta, actually leading to a distal aortoiliac occlusion. CTA of the chest, CT surgery was consulted. CTA of the chest, head, and neck were then obtained, and it showed acute type A dissection with involvement of the aortic root with extension into the left common carotid. Thankfully, her left internal carotid was patent and no evidence of stroke, at least on the preoperative CT scans. So in summary, we have a 36-year-old female with acute type A 11 aortic dissection with evidence of extensive bilateral lower extremity ischemia and mesenteric ischemia. So who goes first? And that's kind of the crux of the talk and the real learning point for me. I think when wondering who should go first, first of all, you need to involve your CT surgery colleagues. You also have to ask yourself, what's going to kill this patient first? The aortic root, her coronaries were perfused, there was no AI, and she had a CK over 220,000. So we thought, and CT surgery agreed, that getting her lower extremities perfused and her visceral segment perfused and getting that lactic acidosis down was the most important thing. So we went with a TVAR first approach as a bridge to definitive repair. And our entire goal for this operation was to expand that true lumen and get everything reperfused. It's as timely as possible. This was before, unfortunately, we had TBE, so we did a zone 2 TVAR with a C-tag and extended that with another C-tag down to zone 5. And then we did a petticoat with the Cook dissection stent from the C-tag all the way to the aortic bifurcation. I think you can see here we have great true lumen re-expansion. And then to reperfuse her bilateral lower extremities, we did kissing iliac stents with just some Viabonds and some very gentle ballooning. She was taken 2 days later, lactic acidosis cleared, taken 2 days later for her aortic root replacement, ascending aortic replacement and hemiarch. They sewed right to our TVAR graft. Woke up from surgery, unfortunately had bilateral lower extremity weakness and was diagnosed with spinal cord ischemia after her open chest surgery. 1 year out though, she is alive. She still has persistent paraplegia, but she is alive and there for her 3 children. In conclusion, when you have acute type A dissection, number 1, first and foremost, load the boat. Number 2, understand what is going to kill the patient first. And then 3, restore perfusion ASAP, whether that's with a stage approach or just straight to definitive repair. Thank you.